Hi, everybody. Thank you for joining us today for our webinar. My name is Livia Dupont, and I'm one of the health educators here at the Global TB Institute. So I think we can go ahead and get started. So our webinar today is Communicating about Public Health in Times of Crisis, Communicating Effectively with TB Patients and Frontline Staff. For our agenda for today, we will be running through a few housekeeping items as well as the speaker introductions, followed by our panel discussion. Then we'll leave some time for Q&A at the end, and we will wrap up and have our closing remarks. Our learning objectives for today are as follows. Firstly, recognize the emotional and psychological impact of the COVID-19 pandemic on health workers and TB patients. Second, apply risk communication principles to develop messages on TB and COVID-19 for frontline health workers, patients, and contacts. Finally, use tailored approaches for communicating with health workers, TB patients, and contacts so appropriate TB care can be provided. Now I will pass it over to our moderator, Nisha Ahmed, who is our training consultant here at the Global TB Institute.
Thank you, Olivia, for setting up the background for us. So we are in an unprecedented time here in the United States with the COVID-19 pandemic. And the way that we provide TB care is changing, and both staff and patients may be experiencing fear and anxiety, which can present barriers to both accessing and delivering appropriate TB services. At the same time, things are evolving very quickly, and as a result, effective communication is even more important than before to ensure that we can provide appropriate TB care to those who need it. Within the TB programs and TB services, however, staff and workers are uniquely well-positioned to focus on this, since within TB, we've always had a focus on patient care and education, and some of the same concerns that we are hearing with COVID-19 around fear and stigma and communicating around contact investigations are also present with TB. However, there are a lot of challenges to communication, and one thing that I think will come out today is there's no one clear way on how to address these challenges. I will also say that we know from you all out in the public health workforce that there's a lot of policy and program issues that you're trying to figure out in terms of TB, how to operate clinics, who you should see in person, who should get service in their homes. And this webinar isn't focusing on that, but more on communication, primarily on an individual level with patients and staff. But there are a number of resources that have a programmatic focus, and we'll be sharing some of these with you at the end of the webinar. So with that, I wanted to say that we are very pleased to have an amazing panel of experts to help us examine some of the challenges faced by frontline staff and managers or supervisors when communicating both with individuals with TB as well as their contacts and others in the community. So we're going to talk about strategies for developing messages and approaches to communication to help ensure that appropriate TB care can be provided, and to help encourage the health behaviors that are needed for care and prevention in TB. So our panel comes to us from a variety of different backgrounds, which I think will really add some depth to this conversation about how to communicate with your patients and clients during this time. So I'm going to start by with introducing our panel. Dr. Alyssa Kosloff is a practicing clinical psychologist. She is an instructor at the Rutgers School of Public Health, and she's also core faculty at the Rutgers Institute for Health Policy and Aging Research. Dr. Alfred Lardizabal is the executive director of the Global Tuberculosis Institute. He is also an associate professor of medicine at Rutgers New Jersey Medical School, and he provides pulmonary and critical care services at University Hospital here in Newark, where he was on the front lines of response to COVID-19. Lynn Mateos is a supervisor of clinic nurses in the Hudson County Chest Clinic. She has more than 17 years of experience providing and managing TB services here in northern New Jersey. Dr. Lisa Mikesell is an associate professor at the Rutgers School of Communication and Information, and she's also associate faculty at the Institute for Healthcare Policy and Aging Research. Her research focuses on patient-provider communication and explores communication practices that facilitate trust between patients and healthcare workers and also help foster patient engagement. And finally, but certainly not least, Dr. Heather Wirtz is a second-year psychiatry resident at Rutgers, New Jersey Medical School, where she also attended medical school. In her residency, she's involved in patient care of a diverse population here in the northern New Jersey area. So, as I said, we're delighted to have this panel share their insights, and we'll go ahead and begin with a question to Dr. Wirtz to sort of help set us up in terms of where we are now in the situation. So, Dr. Wirtz, we've been living with the COVID-19 pandemic for several months now. What are you seeing in terms of psychological and mental health impacts for patients and community members?
What's going on? I'm doing well. There's also, we have to think about increased substance use. I know there's been a lot of talk about, people are bored. They may be drinking more. They may be using more substances in the context of less availability of support for substance use disorders. I don't know if there's any in-person AA meetings at this time, at least in New Jersey. Admission to inpatient rehab is hard because you don't know if patients are COVID positive. And of course, more related to what we're talking about here today, patients have concerns about, their follow-up with their regular health conditions. They're worried about new routines. They're worried about safety of going to the doctor. They're also worried about, what's open and what's not. For example, psychiatry is able to proceed largely as normal. We can do telephone and video appointments, and that's probably true for, say, therapy as well. But if you go and look at pulmonology, cardiology, some of these really require a physical exam. They require testing that will be on site. So a lot of things are being pushed off, and this is leading to anxiety of patients as well. It's really leading to the patients having to kind of weigh out what are my risks here due to not following up with my chronic conditions versus what's my risk of exposure.
Thank you, Heather. That's really helpful. And I want to, later on, a little later in the webinar, we'll follow up a little bit more about sort of the idea of continuing with care for other diseases, particularly TB. So thanks for that description. So I think at the same time as the COVID-19 pandemic, we all know that there have been recent protests and a renewed awareness of the role that race and ethnicity play in public health. So we know within the United States that that COVID-19, like TB, disproportionately affects Black and Brown communities. 71% of TB cases in the United States diagnosed in 2019 were in people born outside of the country. And we all know, unfortunately, that there are poor outcomes and higher mortality rates with COVID-19 in minority communities, especially Black communities. So I wanted to ask you and the other panelists who may want to comment on this, what should healthcare workers be aware of in terms of the emotional and mental health impact of these current events on their patients in the context of the fact that we also have the COVID-19 pandemic going on?
Right. So in the era of the pandemic, many of the inequalities that we've seen in the outcomes for coronavirus, have deep and long-term roots in pre-pandemic realities and issues. The structural discrimination has led to limited access to health care for a lot of people in our country, and unequal distribution of wealth as well. So as a result, Blacks have had higher rates of underlying conditions such as diabetes and heart conditions, which can lead to poor outcomes in the coronavirus as well. Also, we have to realize that, as we discussed previously, people of color are more highly represented in jobs that are essential at this point and they cannot take time off of work. They need to be there to make money. So they're risking higher exposure at this time too. Things like working from home, social distancing, driving versus using public transportation, these are all issues that are related to this systemic discrimination and racism. In addition, the killing of George Floyd and the subsequent protests and, against racism and police brutality have resulted in some significant and rapid increases in anxiety and depression in people of color, not seen in the white community. So even if you're, say, a white, supporter, you're not finding the same level of increase in anxiety. This was in a Washington Post article that we had discussed, they found this data through census surveys. So really, over a period of a week, the anxiety had increased significantly. So what do we as healthcare workers need to know, and what can we do? First of all, we should be prepared to acknowledge racism to our patients. Many people of color are living with this stressor, in their day-to-day life every day. So that's adding to their stress. So in this, in this context, you've got that base stress, and then you've got the increased stress of the coronavirus. So this can increase risk for psychological or mental health issues. In addition, some of this risk is from childhood. So if you're exposed to racism and that baseline stressor throughout your childhood, this can increase your susceptibility to both mental health and medical issues. There have been a number of studies done on this. Secondly, as healthcare workers, we need to call out racism when we see it in action, whether that be a colleague saying something, whether it be mistreatment of a patient, whether it be opinions expressed. We need to be calling it out. We need to advocate for change within our immediate organizations and our communities. We've realized that if we keep silent as, the organization or as bystanders, that is really an implied form of agreement. If we don't speak up, then we're letting the status quo go on. So really that's our role. We need to acknowledge it, and we need to step up and advocate for changes. As far as specifically public health and in the coronavirus time, realizing the disadvantage that people may have due to the systemic racism, in order to maximize coronavirus prevention, et cetera, we need to provide for basic needs so that people can take time off work if they need to isolate. So that may mean wage support or food. It might mean that we need to provide housing for someone if they need to isolate and they live in a house or an apartment where they really can't isolate safely if they've been exposed or have symptoms.
Thank you so much for that really great sort of description of the challenges and the problems and that folks of color are facing in this time, and in general, as you've described, based on the structural and systemic racism. So the reason we're bringing this up here is, of course, TB patients, as I've mentioned, those of us who are providing services to TB patients recognize that it is a disease that disproportionately affects people of color. So I think it's helpful to have this in our mind as we're interacting with patients during this particularly stressful time. Dr. Kozlov, do you have any, as a clinical psychologist, do you have any other thoughts or comments you might want to add?
Hi, let me just start my video for everyone. Thank you. I think that it was well said, and just something to be aware of, I guess, too, is that as healthcare workers, we are not immune to the environment that we are living in right now. And being aware of your own emotional reactions to everything is actually, I think, a helpful and useful tool for working with your patients. And so, if you're experiencing distress, there's a good chance that your clients or your patients are as well. And being able to talk about it openly is a real gift that we can start to give to the community, is acknowledging what's going on, addressing it, discussing it, making it a safe and open space to do so.
Thanks so much, Dr. Kozlov. So what I'm going to do now is ask Olivia to pull up a polling question for all of you in the audience to sort of weigh in about what Dr. Kozlov was introducing, the idea that healthcare workers themselves are having these same impacts. We're all human beings, and it is a stressful time for everybody. So I'm going to invite the audience to respond to tell us whether you've been experiencing increased levels of anxiety or depression since the COVID-19 pandemic began. So I'm going to let you guys have a little while to answer, and then Olivia will close the poll for us. But at the same time, I want to sort of ask some of our other colleagues to talk about some of the, what impacts you might have seen on health workers during this time. So Dr. Lardizabal, I'm going to start with you and see if you have any thoughts or comments on that, since we, as I mentioned, we know you're caring for both TB patients and COVID-19 patients.
Yeah. Hi, Nisha, and good afternoon to everyone. I just wanted to connect to what Dr. Worth has just discussed earlier about the current political climate and the ongoing pandemic. I think it's an important time in the nation. Here we're talking about our anxieties around COVID, and at the same time we're also confronted, or we're asked to face ourselves in terms of a community that has perpetrated sort of a subtle way of inequality in terms of races. And all of these have trickled down, all of these events have trickled down and has shown themselves in terms of healthcare disparities. We see that in TB, we see that in COVID as well. However, what COVID has opened up for all of us is that we're all the same. and I think all of these things colliding with each other at the same time has made it even more important to kind of really think about our communities. So for healthcare workers, I guess needless to say, fear is the most common thing that every healthcare person would be confronted with, especially those who are direct care providers of COVID patients, people who work in hospitals or EMS, those who go around the neighborhoods and picking up people. They're the ones who are frontliners, and there's always going to be an underlying fear, anxiety, and all that. I remember in the beginning that sometime in February, there was a lot of confusion as well with regards to what this is all about. It hasn't fallen on our laps at that time, and we were not sure how to address this. We were trying to be careful not to alarm people, at the same time balance it off to be with being careful. And so there was that hesitancy to kind of like open the gates and tell people stay at home. Right. And we're learning now that if we did that 2 weeks earlier, we would have probably saved easily 20,000 lives. So there was this whole whirl of confusion around all this, at least here in the epicenter in the New York, New Jersey area. So there's been a spectrum of morbidity and mortality among people who care for patients directly, and certainly that has inevitably is going to result in some form of depression and trauma for those who care for patients. We've seen it firsthand. So all of these things are ongoing, but healthcare providers continue to march on and do what they have to do and kind of put everything sort of subliminal, all these fears and anxieties, and just continue doing work. But these are things that eventually will have to be confronted and dealt with.
Thanks, Dr. Lardizabal. That's a really great summary. I'm doing some rudimentary math here, but I'm going to say about 3/4 of the people who responded said yes, they had felt some levels of anxiety and depression since the pandemic began, versus about a quarter who said they had not. So I think that's really telling, since obviously our audience here is primarily health workers of some sort. So what I wanted to do is ask, so given what we're hearing, what Dr. Lardizabal has just mentioned, Dr. Koslov already mentioned sort of one thing that health workers can do, which is acknowledge what they're feeling. But I'm wondering, what are some other strategies or approaches that can help us all, both as healthcare workers and for our patients, cope during this really stressful time? So I'm going to direct that to Dr. Wirtz at first.
Hi, so definitely what we talked about there with acknowledging our feelings is very important. Part of that can be taking those feelings and finding someone to talk to about what you're feeling. That might be a coworker who kind of understands what position you're in or what you're going through. It could be a therapist if you have access to a therapist, someone who's kind of impartial and can talk about it. Not everybody's going to be comfortable talking to friends and family about what they're going through, deep with their emotions and that kind of thing. Also, we really just need to take care of ourselves. We need to take care of our physical selves. We need to be watching out for our eating, our, sleeping, and our exercise, just keeping physical care of ourselves. When we have a lot of stress, then we can kind of let those things go, but we need to kind of keep up with some routines, try to keep up with our, healthy eating, certain sleep hygiene routines, going to bed or waking up at certain hours. As far as our exposure for ourselves, and that anxiety that we're already feeling, the connectedness is very important, but there's a large overlap at this point with our use of social media and our phones to connect with our friends and our loved ones and our source of information. So it's helpful if we can try to not be exposed to the news 24/7, because there's a lot going on. If you can check in with the news, 1 or 2 times a day, and then try to tune some of that out while still maintaining connection with your friends and family. Also, for healthcare providers, I know that I heard from a number of people who really were on the front lines that they took a lot of comfort and reward from their work, knowing that they were doing something that for a lot of them they felt was a calling, that they were really helping people in a time of need. And even if it was very difficult, they had this sense of collegiality with their colleagues, and they felt just a lot of reward for the work that they were doing. So sometimes we have to remind ourselves that what we're doing is important, and we're, we have a motive to help people. So not only is it our job and we're working, but it's also, there's a reward in it, and sometimes we have to remind ourselves of that.
Great. Thank you so much, Dr. Wirtz. So before I move on, does anyone have any other thoughts or comments or suggestions on strategies or approaches?
Yeah, I'd love to just chime in. I do a lot of caregiver research in my job, and I think that a lot of the principles of being a caregiver apply really well to healthcare workers as well. Dr. Wirtz talked about self-care, and sometimes people think that that's a selfish thing to do, but there's a reason why on airplanes we always are told put your face mask on first before tending to others. That's because you can't help other people if you are not in a good place yourself. And so really evaluating your relationship to these things that provide you some joy and some relief, and making sure that they're built into your daily routine. Because if you burn out, you're doing no one any good, right? So the other thing I just want to talk about is that compassion fatigue is a real thing. And it kind of manifests in different ways for different people. So when I say compassion fatigue, we see this a lot in healthcare workers and mental health care workers, frontline workers. And that's the idea that you're giving so much of yourself all the time that you forget to take time for yourself, or you find that it's actually kind of hard to keep feeling compassion for other people. And so if you notice that you're more irritable, less warm towards your family members, your patients, your friends, if someone calls you and you normally would be very quick to talk to them for a while, but you think, oh God, I just don't want to do this right now, these are some nice warning flags for you to take note of, that you're not feeling like your normal best self. And if that's happening, catching it early is kind of a better strategy than letting it go on too long until you, I don't know, blow up at the office or do something that's really out of character for you. So there's some really nice self-care guides out there for caregivers, for healthcare workers, et cetera. But essentially take stock of the things that fill your cup up and make you feel like you again. And make sure you get a lot of access to that, especially now when it can be even more challenging to figure out, well, what do I even like to do in a world where I can't do what I'm used to doing? So put some of those things in place to take care of yourself.
Thank you so much, Dr. Kosloff. That's really helpful. So we're talking about this aspect of sort of where we all are now, and the anxiety and the depression and the fears and the burning out that we're all facing, because all of those things are huge. And as we were talking to folks here at GTBI and other folks in the field, we recognize that all of these things can be barriers to effective communication, to working well with patients. So what I'd like to do now is switch from sort of the stage setting of where we are to talk a little bit now about some challenges and strategies for improving communication. So I'm going to start by asking Dr. Mikesell, so during a time like this that we're facing now with COVID-19, what are the challenges to effective communication?
Yeah, so I mean, I'm sure the list of challenges for everyone is facing is quite long and varied. But for me, I'd like to highlight, I guess, two challenges that immediately come to mind, and I think both are challenges that kind of can be turned into opportunities to build rapport with patients. The first challenge centers around uncertainty, which many people have already mentioned. So there may always be some level of uncertainty in medicine, but of course it's much more pronounced living in a pandemic, particularly with the novelty of COVID, where information is changing constantly. So there's certainly uncertainty for patients who may be wondering, what options are available to me? What's the risk of taking one of those options? They might have put healthcare off. And now we're wondering, is this the time to act? What's the risk for acting now versus later? Right? All of this are wrapped up into this, this notion of uncertainty. But there's also uncertainty for the clinicians and experts and healthcare workers, and because the data is changing and the predictive models are constantly being updated, and it's frankly really hard to keep up. So I think, understandably, as experts, we often want to be very clear and decisive. And that means that sometimes uncertainty can be buried or muted when communicating with patients. But there's a recent series of studies that is showing that, transparently, openly communicating about uncertainties that you yourself might have with patients doesn't actually erode trust, and it can be an opportunity to build trust with patients. And of course, knowledge is also important. So this isn't to say, to not communicate what you do know with certainty, especially knowledge from, a trusted expert is quite powerful. And I think, we're all right now craving some consistency and consensus. But I guess I'd also not avoid discussing elements of uncertainty that you might have altogether. And then the second challenge for me really relates to this idea of connecting, I think, which is perhaps more pervasive across healthcare contexts and across time, but perhaps more highlighted now during a pandemic. And it might be more evident in healthcare encounters that aren't centered around kind of mental health needs. So something we hear from all kinds of patients in all kinds of contexts pretty frequently is that they don't feel heard. And this doesn't mean they're not satisfied. These same patients are sometimes rating their encounters as highly satisfied, and they really like their clinicians, and at the same time they're saying they don't feel heard. And I think sometimes it's hard to know exactly, well, what does that mean that they don't feel heard? But I think it can help to remember that healthcare encounters, particularly for patients, are very institutionalized, and reasonably so, right? They're very task-oriented, they're very instrumentally focused, usually with very clear clinical objectives. Again, this is very reasonable. We all come to this encounter expecting that kind of engagement. But patients also come with real fears. They come with real concerns that sometimes aren't automatically afforded space during these very institutionalized, well-defined encounters where healthcare needs need to be met. So particularly, during COVID, where there are all the protests, social unrest, I think, there's likely to be increased health anxieties and social anxieties. So I think making a conscious effort in whatever ways you feel comfortable to build in space for patients' agendas to surface might not be entirely focused on the clinical objective can really go a long way. So I think in the context of COVID, as much as this is a challenge, this can also present an opportunity for building connection, because at least anecdotally, many of the patients that I've been talking with over the last few months, they've mentioned that their visits now often begin with some conversation with their providers and healthcare workers about COVID, whether it's commiserating or talking about challenges or ways that they've been able to deal with those challenges. And they've mentioned it's kind of oddly nice to kind of have this moment of before the official business begins, because it gives a sort of opportunity that isn't always automatically afforded for them to sort of talk about what they're afraid of, what kinds of anxieties that they're having, and it can arise kind of more organically that way.
That's really helpful. Thank you, Dr. Mikesell. So I want to sort of thank you for sort of describing ways to help patients open up with fears and anxieties and sort of give them a space to talk about it. Does anyone else have any comments on sort of approaches to do this, to sort of build rapport and create a space for effective communication? Dr. Kozlov, any thoughts?
It kind of depends if this is via virtual space or in person. I think a lot of people are conducting their visits virtually right now. And that's kind of its own beast, right? Like, I've actually had a virtual psychotherapy practice for 2 years, and have thought a lot and learned a lot about how to conduct virtual visits and how to build rapport virtually. And I think this seems so obvious to say, but I think we're all so used to multitasking whenever we're on our computer or on our telephones that even the simple thing of imagining that the person is in the room with you, and would you respond to a text message while they were in the room with you? Would you respond to an email? Just really giving them your full attention while you're on the visit with them virtually can make a difference. I mean, I think about this all the time. When I call my husband and he's at work, back when that was a thing that we were allowed to do, I knew right away if he was multitasking or giving me his full attention on the phone. Our clients, our patients do as well. So, clear the desktop, close everything down. If you're having a virtual visit, pay attention to them, and it will feel different. The other thing that I would, thank you, I like that comment, Lauren, thank you. The other thing I would say too is that there are things that are lost in translation over phone calls and video calls, and acknowledge that, right? If you're doing a phone call with someone and if they say something difficult, you can say, like, you can't see my face right now, but I'm feeling really compassionate for you, or my heart hurts for you in this moment, because we're losing all the nonverbals, and those nonverbal communication techniques is how we feel connection a lot of the time. So to the extent possible, communicate the nonverbals. There is also an interesting article, I think in the New York Times, about why people are having Zoom fatigue. That there are these nuances that are lost in the digitization of our contacts, and acknowledge that, right? So just pay attention to it, like, oh, there was a lag and you maybe didn't hear me, or I may be responding in a slightly off way, but we can still have a meaningful communication right now if you're present and there for your patients.
Thanks so much, Dr. Kozlov. So I'm jumping a little ahead here, but can
I just say something?
Yeah, please, of course.
Dr. Kozlov, these comments are very important these days. When we teach students about provider and patient communications, we always say start with building a rapport. And as mentioned earlier, you talk about something, give a little space before getting down to business. But not aside from just the talking, a lot of the nonverbal, as was mentioned, is important. Your posture, you're leaning forward, you're saying your facial expression, all these things help connect. And now we don't have that. In addition, you might be totally covered with PPE. And so you really have extra challenges these days in terms of building that rapport, and verbalizing these things is really a very important thing to remember. Thanks, Lisa.
Thanks, Dr. Dr. Lardizabal. So we all know on this call that establishing trust and rapport with patients has always been a really important part of TB services. And patients form relationships with people who they're going to see frequently, sometimes over 6 to 9 months. So we also know that right now a lot of these services are being provided over the phone or by telephone. So one thing I want to call out is that relationship building is critical to identifying close contacts who need to be evaluated. When you're conducting a TB interview to identify contacts, in the past that was done in person with an opportunity to connect to the person, to provide education. You may not necessarily always ask about contacts on your first interview. You might first focus on the relationship building. So I'm going to ask Lynn Mateos to talk a little bit about what you've been finding with doing contact investigation over the phone these days in your clinic. Lynn? Oh, it looks like Lynn's muted, so you'll have to unmute yourself. Oh,
can you hear me now?
Yes, we can.
Hi. So going back to rapport, it's hard. It takes time to establish that. You cannot just call the patient and say, hey, I'm so-and-so, I need information. So it's a process. Our social worker is so good at getting those information that we need for our contact investigation. She's really good at that. She FaceTime, she uses all the gadgets. She FaceTime the patient. She uses the laptop if the patient have laptop in the hospital, because we can't get into the hospital because there's limited number. They don't even allow visits. So everything is done by phone. She would talk to the patient, call the patient when the patient is most comfortable. So she would alert the patient, I will call you at 9 o'clock. Will that be okay with you? So she gives the patient choices. So sometimes it takes 2 to 3 or more calls before she can get all the information that we need for our contact investigation.
That's great. Thank you, Lynn. So Alyssa talked a little bit about strategies for building trust and rapport and continuing to show that sort of empathy and compassion using the phone. Another thing that we've seen during the COVID-19 pandemic is health workers, outreach workers, nurses, et cetera, have these close relationships with patients who they may have been seeing if you're getting directly observed therapy every day for a month. And sometimes, and not sometimes, that changed very rapidly, and patients were no longer being provided DOT, sometimes in person, and patients may be feeling sort of abandoned or isolated, sort of in the context of already feeling isolated, and in addition, this person who has been supporting them with their TB treatment for several months is no longer there to provide that service in person. So I'm wondering, are there any other sort of thoughts or suggestions on how to address this and maintain this connection with patients who may be feeling sort of a loss of their interaction with their health workers? So I'm going to maybe start with Alyssa on that, but anyone can feel free to jump in.
So it really kind of depends on what your clinic is able to do. If you have the bandwidth to do check-in calls, I think that would go a long way, because we've built this community and this social habit, really, of having regular contact with your healthcare providers. If there's a way to continue that in small ways, I think that would do a lot, especially for assuaging some of the anxiety that people might start to feel about coming back into the clinic, right? Having some of that regular contact throughout so that they can ask their questions, voice their concerns, and have the ear of someone that they know and trust to bounce ideas off of for how to mitigate the risks, I think is a really powerful intervention. I understand that not everyone has the bandwidth to do these kind of friendly phone calls or friendly check-ins, but you know, it's hard. There isn't a perfect proxy for in-person contact or regular communication. So to the extent possible, finding ways to stay connected and acknowledging that you haven't, right? You know, we're now in month 3 of being socially distant, and if it's time to call and schedule an appointment, maybe giving it an extra couple of minutes to say, how have you been? We're sorry, we've missed you. You know, we haven't had a chance to connect. How has it been going? And acknowledge the shortcomings of the system, right? It's not your fault. It's not their fault. It's that we have a healthcare system that doesn't really allow for the number of touch points that we know make a really big difference in care. So, you know, that's a place to start.
Great. Any other comments or suggestions on that sort of maintaining trust and rapport in the presence of this rapid change in the way services provided? Dr. L?
I think that, you know, the anxiety is definitely out there, and one way to lower the anxiety levels and prepare people to come back into face-to-face evaluations or care is to start with clear data, you know, explaining that processes within the facility, whether it be a chest clinic or an office, are going to incorporate best practices for infection control. I think all of these preparations will help lower the anxiety level. Without a doubt, everybody's already heard everything they need to know on TV, maybe too much. So they know what important steps are needed to be taken when merging back into crowds or stepping out of their homes, wearing masks, hand hygiene, and all those types of mitigating behaviors. But in terms of increasing the comfort level for them to go back into the fold, I think it starts also with expressing the fact that everything has been thought of. We've prepared. We have screening techniques beforehand, and then that would sort of ease their coming back into kind of like face-to-face contact as we used to do.
Great, thanks, Dr. L. So that's a nice transition into our next polling question, which I'm going to ask Olivia to pull up. So as TV services are starting to resume again in terms of in-person patient care, and clinics are opening up again, I'm wondering from the audience, have you had TB patients or contacts who have not wanted to or refused to come into the clinic for fear of exposure during the COVID-19 pandemic? And so while you guys are answering that question, I'm going to sort of pose a theoretical to the panel. So let's say you have, there's a TB patient who is experiencing potentially severe adverse effects from their medication, which is something that would require an in-person visit for an assessment. And that person doesn't want to come in for fear of exposure to COVID-19. So I think Dr. Larzabal started a little bit with some approaches on how you might address this, but I'm wondering if I can toss it out to the panel for some ideas and suggestions on someone who has that fear and anxiety, and also could have had a personal loss. There could, here certainly in this area, and in other areas where there is a lot of COVID-19, people may have family members or friends who passed away, and they may have real fears and grief and anxiety about these things. So in this theoretical scenario, a person who needs to come in to be evaluated for potential severe side effects and doesn't want to come in because of their fear, how might you approach this? And I'm going to, does anyone want to volunteer for a first
I can talk a little bit.
Great.
So this is a really hard question with a lot of uncharted territory.
Yeah.
But I think we're really starting to understand that there's anxiety, which we've known about anxiety for a long time. And we know that anxiety prevents people from doing things, right? The easiest way to not feel anxious is to not do the thing that makes you feel anxious. And that's a really reinforcing way to live your life. If you don't want to feel anxious, you don't do the things that make you feel anxious. But the problem there is that your life can get smaller and smaller and smaller if you're never doing the things that make you feel anxious. And we're expecting, the mental health field is expected to see a huge uptick in anxiety when it's time to do reentry things, because we've essentially conditioned ourselves through the media and through, for very good reasons, that exposure is something that we should avoid at all costs, right? So now we need to start to tease apart, am I not going out into the world because of my anxiety or because of a real risk? And I think one of the ways that we can start to tease that apart is, what is the risk of not going into the world again? And if we're talking about, getting really important health care for your chronic condition that your medical practices, your medical providers are saying you need to come and get, that's where we have a pretty clear piece of information that if you don't come in, then the anxiety is overruling the medical advice. And so how do we break down the anxiety so that we can say, okay, it's no longer the risk that's keeping me home, it's my fear. And fear is something we know a lot about. We can tackle fear, we can tackle anxiety. You can ask questions like, well, what do you lose by not coming in? And that's something that your medical providers can talk through, the risks of not coming in. Are there ways that we can mitigate the risks of coming in? Talk through all the different things that the clinics have in place, talk through a transportation plan, talk through, exposure amounts and things like that. And if things start to get really bad, if there are other activities that people are not doing because of anxiety and not really because of risk, that's where we have to start looking at anxiety treatment. There's never a 0% risk of doing anything. When you leave your house to go for a walk, there's some percentage of risk that you will not come home from that walk the way that you left, right? There's accidents that happen. You can slip and fall in your own house and have something bad happen. So at some point, we take on risk because it's an activity that has value to us.
Right.
And I think seeing our healthcare providers is an activity of value that deserves the appropriate steps to overcome the anxiety hurdles.
Great, thank you. Go ahead, please.
Yeah, I think the term person-centered care has been quite fashionable the last year or so, and it's something that we in TB have been doing for quite a while. It's really part of all this effort is case management and talking through barriers, and as Alyssa mentioned, fear is probably one of those. So our nurse case managers are very good at that, and I'm sure Lynn has some examples as far as how they've handled this when the situation arose. Is Lynn able to comment?
Yes, Dr. Lardizabal. We have offered masks and gloves to the patients that are afraid of getting the virus stepping out of the house. So we have field reps drop off masks and gloves. And if public transportation is an issue, we have a van service. If it's available, utilize it. We have our van driver on call. So if in case we have a patient that does not want to take public transportation, we call her, she picks them up, drop them off. It's one patient per trip, so there's less exposure. We have a patient that did not want to sit in the waiting room, that just keeps walking up and down the hallway, which I said, let her walk up and down the hallway if it makes her feel better.
Yeah.
So most of the times, things can be done by, just listening to the patients. You don't just disagree right away. You give them options. That's what works in our clinic, giving them options. Even the nurses volunteer to go to the patient's house if it's just a blood draw. So, you know, a couple of times we had a patient that liver enzymes are elevated and patient refused to come to the clinic. So one of the nurses volunteered and said, you know, on my way to work, I'll just stop by the house and draw the blood. And that's how we get things done. Just like supply materials if it's available, if it makes them feel better.
Thank you, Lynn. Those are all really helpful suggestions. So I'm going to maybe just ask Dr. Mike Sell, do you have anything to add sort of about other techniques or approaches that can help encourage desired health behaviors when people are having these feelings of anxiety and worry?
Yeah, I mean, for me, I think immediately about persuasion, communication, and you know, when you're trying to consciously change someone's thoughts or actions. And I think sometimes it can be useful to consider what sort of influence you want to have, right? Do you want to shape a patient's response? Do you want to reinforce their response? Or do you want to actually change it altogether, where you're not just saying, here's options and I think you should choose this one, but you're trying to discourage them from choosing an option that you think is not the best one for them. And so usually it's this kind of third category that we're most concerned about when we want to change their response, right, where we're trying to actively change their behavior. And there are kind of two theories that work in concert that are most often drawn on to inform techniques for inducing behavior change. And so I'm going to try to simplify them. But the idea is that we're focused on behavioral intention. That's sort of the immediate precursor and the best determinant of what actual behavior they'll take. And so when we think of how do we want to tap into their behavioral intention, we can think of usually three things. So their attitude towards the behavior. So this is something we had talked about earlier, where like you want to give space for their agendas to surface. You want to kind of think about what is their feelings and emotions towards this behavior. Sometimes they might volunteer those. Sometimes you might have to explicitly ask them. So that's one when I think about attitudes towards their behavior. And then there are subjective norms. Like these usually stem from our perceptions of, the people who are important to us, right? Our family, our communities. And then we also want to think about their self-efficacy, right? Their capacity to perform a given behavior. Like, do they have the control or power to carry this out? Do they perceive themselves to have the control or power to carry this out? So attitudes of behavior, subjective norms from the community, and self-efficacy are kind of the sort of triad, the three things that might influence what kinds of actions they're going to take or decisions they're going to make. So I think when we put this into practice, we need to sort of first take the time to understand how do they feel about this action that you're recommending or the health behavior that you're hoping that they'll undertake. If it's not something they vocalize on their own, right, that's the first place to start. Figure out, right, how do they feel about the behavior you yourself are advocating for. The challenge is if they're vehemently against what you're proposing. So is it because of some social or cultural norm of their community, or is it because they don't think that they can actually, or they're not capable of engaging in that behavior? So if it's an issue of ability, is there ways that we can address it in this encounter, right? Can the health behavior be broken down into incremental steps, for example, that might be more manageable? Or are there alternative services that might help address some of the feelings of inability or some of the obstacles they're facing? And so what things that Lynn was mentioning and where she's at, right, are kind of wonderful for this, right? If there are things that they feel like they can't physically hurdle over these obstacles, can we bring some of these things to them, is one way of sort of addressing that kind of issue of self-efficacy. I think if it's a normative expectation that comes from their community, right, these sort of social norms, this is the one that's really challenging. Because cultural narratives and these sort of social norms or expectations, they might not be in alignment with the clinical values and professional norms that many of us are enculturated into. So I'd say the first thing is very much like what Lynn said, right, is to kind of recognize their values. Don't dismiss them. As hard as that may be, that's sort of my knee-jerk reaction is to always be like, that is absolutely false. That's an irresponsible belief. But this is, we know, is not effective. Right. But these kinds of social norms that we're tied to. So I'd say that first is just don't dismiss them, as hard as it might be. Simply telling them that they're wrong, which they very well may be, is unlikely to be effective. And you want that person to receive the healthcare services they need. So I think, taking a second to recognize their value systems, you don't need to validate their beliefs that might not be right, but at least acknowledge them, right? I hear you. This is sort of the I hear you moment. And then if you can, try to connect your own professional and clinical values to their value systems and cultural narratives. If that's like, I can't do that, that's too hard, you might just reflect your own value systems and how they're relevant to this particular patient, right? So if they don't want to engage in a particular health behavior, whether it's around COVID safety or TB care, you might say kind of, I understand, right, there's so much uncertainty around COVID, it's hard to know, what to do, what to believe. And you might present what you do know to be true or the best evidence you have, though facts often are not great at tackling kind of the emotive cultural narratives we hold. But if you then express how your values are kind of focused on the interests of that patient, right, that our priority is to do the best we can to keep you safe and provide you the best healthcare, it's harder to sort of squash that, right? It's harder to kind of mute that because it's coming from a place of I'm caring about you as an individual patient, and that's part of my value system. And so it's usually hopefully a better, it doesn't always work in all cases, but as a strategy that might be a sort of second option to just shutting them down or kind of saying that their value systems are not or incorrect or not kind of what you're believing.
Thank you so much. That's really helpful. Does anyone else on the panel have any comments? And if not, I'm going to move on to another potential scenario in TB. Anyone to follow up on that? Okay. So another challenge I think that was brought up was that right now patients and providers are very focused on COVID-19 currently. And as a result, TB, which sometimes can have similar symptoms, may not be considered, which can result in a delayed diagnosis. So moving out from patient communication to sort of communication with other providers and other institutions, what can we do to keep TB in the minds of folks who are hearing about COVID nonstop? What can we do to ensure these providers are still considering and evaluating for TB in patients who are at risk? And Alfred, I'm going to start with you, if that's okay.
Sorry, I would repeat the question?
Sure. So this is actually the one you and I discussed yesterday. So right now there's so much focus on COVID-19, right? And as a result, TB, which it may not be considered, and which can result in a delayed diagnosis. So what can we do to ensure that providers are still considering and evaluating for TB in patients who are at risk, and that it doesn't get swept under the rug in all of the fear about COVID?
It's a tough question. Even in the absence of COVID, sometimes tuberculosis is not thought about to begin with. And so on top of that, you throw this epidemic that everybody's focused on. And so there's a higher likelihood that the diagnosis of TB could be missed. I don't know what else can be done to kind of promote that differential, and so it goes back to being aware of epidemiology and data and all that, and I think it's beyond our capacity or the capacity of public health to address all these problems. But definitely, it's a possibility that these two diagnoses can present simultaneously. Certainly, just yesterday, a new patient was brought to my attention who has been having breathing issues for more than a month, presents to a hospital and gets COVID tested and is COVID positive. But COVID doesn't linger for kind of a slow month. And so in addition, the patient also had a pleural effusion, which is not typical of COVID. So these two entities can indeed coexist. Unfortunately for this case, sputum was collected and sent for MTB, and lo and behold, 4 weeks later, it grew. So it's always important to stay aware of the possibilities of both. The disparities of these two diseases tend to affect the same individuals, people of color, and those who have been born outside of the U.S. So it's being aware of these possibilities that we hope clinicians and emergency rooms will keep in mind.
Does anyone else have any sort of thoughts about how to draw attention to other issues when there is a crisis going on like this in terms of COVID, but recognizing that other care also needs to be provided? Any other thoughts or comments on that? So I want to, this is such a fascinating discussion, and you all have so much experience, but there's several other topics I want to try to get to. So I'm going to toss out one more potential TB scenario, and then we'll move on to some messages and providing information about COVID and TB. So my last sort of patient scenario, TB scenario is that let's say you're managing a clinic and one of the outreach workers who you supervise is concerned about going into the field and putting themselves at risk and worrying about their family. So this sort of ties into what we were talking about at the beginning. So how might you approach a situation like this, given that what we know what the risks are and what we know the fears are? So maybe, Lynn, I'm going to start with you and ask if you've had experience with that.
Oh, yes. Hi. Yes, true. Sometimes the staff would come to me and just discuss their fears. They would sit down and just talk about it. It might be a different scenario the next time they come and sit in my office, but sometimes I just have no answer. With information changing, I just tell them I really don't know the answer. And sometimes I just sit and listen. I just let them talk. Sometimes I don't make comments. I just say, okay, I understand, you're having, you're scared of going out to the patient's house, or you're afraid for your family. But sometimes I just don't say anything. Just listen. I just listen. And sometimes when they leave the room, they're not as upset or as anxious as when they enter the room. I don't know if it's just allowing them to talk would make them feel better, but that's what I've been doing since this pandemic started.
Great. Thank you, Lynn. Does anyone else have any sort of thoughts or comments on that situation?
I could add to that. I think there is a question on the chat box as well, and it has to do with assuring safety in the clinic. So I think the fear of staff and all these things have to do with how we administer policies and all those things in clinics. So I think you can really lower the anxiety level if you have the proper policies in place. So for instance, if we're planning to reopen the clinic slowly, I think in terms of structurally, appointments have to be strictly scheduled, adhere to those schedules, and they have to be kind of separated so that patients don't kind of congregate in the same spot when reaching out to a patient. Certainly, the opportunity is there to do a symptom screen, a travel screen, a contact screen. All of these things can be upfront. Scheduling done properly can kind of lower the likelihood of having infection transmission within the facilities. Simple things like advising patients who have an appointment to come by themselves if possible, and one person at the most, and not the whole family. Things like that. When they enter the facility, you have a hand hygiene jar before stepping into the facility. A person is there to symptom screen and temperature check, and hand sanitation in the room. PPEs for the healthcare provider, and now PPEs for somebody who's low risk for COVID. I think it's sufficient to have just droplet precautions, which is gloves, kind of a face shield with a mask, a surgical mask. Some might want to take it a step further, and wear a clothing cover so that they don't get it on their clothes, and that's fine if there are supplies for that. And certainly another point would be cleaning the room after the last encounter. So having all these things in place is going to be good for both the patients and is going to be good for the staff as well.
Thanks, Dr. Lardizabal. I mean, it's a really good sort of example of the synergy between the policy and the communication, right? Not only does you have to establish these policies, but then make sure that the folks who are having these fears are aware of what you're doing to protect them. So does anyone else have any comments or thoughts on this potential scenario? I mentioned a health worker who's fearful of going out in the field because of the risks for their family. Any ways to approach that, in addition to what Dr. Lardizabal and Lynn have already mentioned?
Well, I'll add on to that.
Okay.
Sorry.
Great.
Only if absolutely necessary is what we've been doing.
Okay.
All right? There's no need for unnecessary travel in these times. So, if there is something that's critical enough for you to go out and visit, go. But otherwise, everything can be done virtually. Okay? And so a lot of TB control prevention work has turned into a virtual thing. Contact investigations, congregate setting investigations, and doctor visits. So, and DOT. Suddenly, our clinic is all electronic DOT. So really, there is very little reason to be going out there these days because there are other options to carry out that work.
Great. Thanks, Dr. L. So I want to maybe transition now into messages and providing information about COVID-19 and TB. So in the various questions we got during the applications, there was a lot of questions about the fact that people are hearing a lot about COVID-19 right now. And we know there's some similarities with TB, but also some differences in the prevention of care of TB versus COVID-19, which may be confusing to patients who are hearing all this stuff nonstop about COVID. So I'm wondering for Dr. Lardizabal and Lynn, if you can talk about what are some differences and similarities between the two diseases that are important, especially important to communicate to patients during this time, so that they understand their TB and they can likely to be able to carry out the desired behaviors. So Lynn, do you want to start, or?
I'll have Dr. Lardizabal.
Okay.
So both are respiratory diseases.
Right.
So they have a lot of overlap, a lot of non-specific symptoms that they share, cough, fever, shortness of breath, chest pain. All of these are shared. The difference between the two is the temporal difference between the viral infection and TB. So you get infected with TB, you can be totally healthy for many decades and not be sick. And if you do get sick, this is a subacute type of process, which sometimes patients don't even recognize as happening.
Okay.
As opposed to COVID, it's certainly a more rapid change in your physical state. So you'll be really fatigued. You'll have terrible headaches. You'd have, just like the flu, myalgias. You might have diarrhea. So there are parallels with regular flu and beyond that, wherein it could rapidly deteriorate into a respiratory failure. So as many of you know, the COVID-infected individuals, a vast majority of them are asymptomatic to mildly ill,
right,
not requiring hospitalization. and the upper, you know, 15, 10% are the ones that need to be hospitalized, and then even further, the ones that don't make it through. And that depends on your risk factors and age. So you've heard Dr. Fauci talk about this a lot, and so I think most of you are aware of that. Listen to him. And so there are distinct differences between the two, and those are the things we can discuss with patients. Sure, they share things like cough and anything that affects the lung, but there are more differences between the two, really, essentially, in terms of severity, acuity, etc.
And so I think that's a really important point, because as people are conducting contact investigations, we're used to hearing, oh, 14 days from COVID, you know, if you don't get sick in 14 days, you're in the clear. But that's something that's very different, as we know, with TB, so that patients may not necessarily understand. So in the interest of time, so Lynn, did you have anything you'd like to add about, from your experience, what you think is an important message to convey to patients about the difference versus TB and COVID that will help them continue their TB care or understand?
What I could think of when we're doing the contact investigation. Two different. When we do contact tracing for the TB, patient is infectious. We go back as far as 3 months or more prior to the symptoms appearing. TB patients can be infectious 3 or more months before they feel that they're sick. But with COVID, I think it's only 2 to 3 days before, 2 to 3 days before the symptoms that the patient is infectious. Whereas with TB, you have to be exposed for a long period of time to be considered a contact, like an 8-hour exposure. With COVID, I think it's only 15 minutes exposure before they consider you as a contact.
So that's interesting, the difference in terms of the risk of exposure between the two diseases, and having folks understand that. So that's helpful. What I'd like to do now is build off something we talked about earlier, which is that one of the challenges with COVID is that there's so much we don't know, and recommendations and practices are changing as more information becomes available. So we talked a little bit, I think one of our speakers talked a little bit about acknowledging the fact that there are uncertainties, and acknowledging that you don't have all the answers now. So I'm wondering, as frontline workers and as managers, are there ways to sort of increase the likelihood that our people will trust us and believe our messages in general, and also how to do this given the fact that things have been changing? Any volunteers to speak to that first? Lisa, maybe?
Yeah, and I'll give it a try. It's complicated.
Of course.
I'm running through my brain about how to approach it. I mean, I guess when we think about kind of interpersonal trust between patients and providers, there are kind of a few components that sort of really surface and really are kind of powerful for patients anyway, in developing trust and sustaining trust. One is honesty, which I think sort of harks back to what we mentioned before about, kind of openly and sort of transparently discussing uncertainties. So, avoiding intentional sort of falsehoods obviously is part of honesty. But the other is fidelity, and I think to me this relates a little bit to the what I was talking about with kind of social norms. And fidelity is, in the to know they want sort of a demonstration that clinicians are really pursuing their best interests, and that it needs to be demonstrable. Clearly you are, but for them it needs to be demonstrable, and we can't, as patients, always evaluate competence, like clinical competence, and so fidelity is often how we access that. And so if there's like in the social norms example, right, sort of clearly showing that my values are you, right, that I have you and your interests are my interests. I think that can often, making sure that that's clearly communicated and explicitly communicated and not just assumed to be heard or understood, I think can go a long way.
That's great, thank you. Any other comments on sort of keeping trust and confidence of patients and staff as our guidance and recommendations are evolving?
I would just say that, you know, we said before that it's important to acknowledge that we don't know everything. It's a new coronavirus, you know, it's new to us too. Even the, you know, most expert physicians really don't know everything at all times. And our patients do look to us to reassure them and give them all the information. But at some point you may have to say, you know, here's the information we have at this time. This is the best of our knowledge, you know, and kind of, you know, admit that this is where we are now and this is where we hope to be. And, you know, just to sort of, we have to acknowledge that uncertainty. We don't want to fall into the trap of feeling that we need to give an answer that's, you know, that sounds assured, because in that case, you may end up giving misinformation. And really, you know, along the theme of honesty, we don't want to feel this drive to give an answer when we don't have one. So just don't fall into the trap of giving misinformation.
Thank you, Dr. Wirtz. That's really helpful. And actually, as you were speaking, it occurred to me, I mean, what about if you're having this interaction with the patient saying, this is what we know now, but you know, as your clinician, I want you to know that I'm keeping up with what's going on, and I will continuing to figure out what the best things are to do, and we'll change as needed, or I'll let you know. Is that an approach that could be helpful?
Yeah, that sounds very smart to me. I mean, I think that most physicians who are caring for, you know, COVID patients or any other patients are trying to keep up on top of the knowledge, you know, the current literature, et cetera. And so just to let the patients know, you know, I mean, there may be questions, say, about medications that have been discussed in the media as, oh, this medication is going to be the answer to all our problems. And then we'll come back weeks later and say, oh, no, that wasn't right. So you may have to kind of explain to patients that, you know, this is new to us, but we're learning as best as we can as we go and keeping up on any current data and knowledge, you know, that is out there and available.
Thank you.
I'd like to add, Nisha, that aside from acknowledging what's uncertain, I think we also have to clearly state what we know and what we know is certain, which is that social distancing, avoiding crowds, wearing a mask, these simple things we are certain has helped us get through. So, you know, with all the politics out there about whether or not to wear a mask, you know, we've seen it here in New Jersey. And, you know, there's a reason we have brought it down. It's a very clear testament to the techniques, very simple techniques that have worked for us here. And so for all those who have not experienced what we have experienced here, stay safe. There's simple ways to do that. And those are the 3 steps that can easily be taken.
Thanks, Dr. L. So that was sort of my last formal question was, we do know there's a lot of misinformation out there, and there certainly has been politicization. And it's not our role to necessarily change people's opinions, but when something has a safety impact, for example, let's say you have someone who doesn't believe that there's a risk of contracting COVID-19 and refuses to wear a face covering when coming to the clinic. So they have misinformation and they are doing something that is important for a healthcare worker to address in terms of safety. So what are some strategies and approaches that you might use in a situation like this? Lisa, I heard you say earlier that, you know, just telling someone the truth or telling someone something accurate doesn't always convince them. So any thoughts from you or Alyssa on strategies for this? Or anybody else?
Go ahead, Lisa. I'll let you.
Yeah, and I think this is by far the biggest challenge I think we're facing, especially, as was mentioned, the sort of political polarization that we're facing around public health issues, which is a little disheartening, I think, for everybody here. But, I guess, just to reiterate, first thing, don't dismiss their beliefs. You're probably not going to change them. We know that from political communication data, from social psych data. It's very hard to change someone's beliefs that are so tightly wrapped up into value systems and social norms and cultural narrative, right? Those are very powerful. So, recognize the beliefs, do the I hear you moment, right? I hear what you're saying. I kind of understand where you're coming from, even if you don't. And it's not, as was mentioned, it's not inappropriate to lay out the facts, right? I mean, knowledge can be quite powerful. I mean, especially coming from an expert who is trusted, which everyone I'm imagining that's watching this, is dealing with patients who really do trust you as experts. But the facts alone aren't often effective to combat misinformation, particularly misinformation that is tied up to these sort of cultural norms and narratives. So objectivity often isn't going to win against emotive and value-laden misinformation. I mean, we know that to be abundantly clear. So I think we need to sort of make that effort to kind of hear and connect with those emotions and values, as hard as it might be, because they're not in sync or they might not be aligning with our own. So, I think as much as, again, you can try to sort of connect correct information or your own professional values to the values that the patient might have, or, when we were talking last week, I mentioned, stories can be helpful here, right? If a patient doesn't believe COVID is real, if you have personal experience or been impacted by COVID in some way, or a family that's been impacted, I mean, for us in New Jersey, I think all of us know somebody that's been significantly impacted. And I think, speaking to that personal experience can help communicate the realness from a human perspective, and also help communicate your own kind of value system that's tied to this issue. And again, the fidelity issue, like, this patient is my priority, right? The last thing you want them to do is sort of get up, walk out, and never come back. And so that's really, to me, what the objective is, right? So we're trying to keep them there and returning. But there's probably other things to add, but I'm starting to ramble.
No, that's really helpful, sort of that combination of the personal narrative and the stories and the fidelity along with the information. Alyssa, did you have anything you wanted to add?
Yeah, I would just say also, the scenario was someone not wanting to wear the mask into the office. I think that we get to also set our own professional boundaries as well. So someone doesn't have to believe in it, but that doesn't mean that they're allowed to not do it. We're all in healthcare. It is our job to keep ourselves and our patients safe. And so maybe it's, if Lisa really eloquently described why it's so hard to change people's opinions, and maybe that's not the goal. Maybe the goal is not to change someone's opinion. It's just to get them to do the behavior so that they can get the care from you that they need. And if that's the case, we don't need to go into the politics and the science and the this and the that. It's just, we want you to come into the clinic. These are the expectations that we have set forth in accordance with the CDC guidelines. If you are uncomfortable wearing a mask into the clinic, we can talk about strategies for a workaround if one exists. But at the end of the day, no one's coming into the clinic without a mask, and there's no, we can draw a line in the sand there. I think we have to.
Thank you, Dr. Kosloff. I think that's a great place to pause. And I know we've already used up almost all of our time, but I do want to allow time for questions from the audience. So I'm wondering, are there any questions coming in that are communication related? I think we talked about the politicization already. So I want to actually, I'm going to pull out a question that came up in the applications that I think might be helpful for people. So in discussing, and while we have other questions coming in, so this may be geared towards Lynn and Dr. Lardizabal. Right now, who is it most important to communicate with about TB risk during the pandemic, knowing that we have limited time and resources, because many of us are being pulled in other directions, so and maybe involved in the COVID-19 pandemic, so we have less folks available. So who should we be focusing on communication with TB right now?
Me From the healthcare provider standpoint?
Well, from the program, I would say from the program perspective.
Yeah, it's a challenge. You know, a lot of other programs out there handle multiple things, are not just assigned to TB. You know, some localities have a staff purely devoted to TB, but many others have to deal with other simultaneous problems. So it is a challenge, and it takes leadership and awareness to make sure other issues don't fall through the cracks. And so it's a juggling act for a lot of health departments out there.
Great. Any other comments on that? Okay, so I think most of the questions that are coming in are mostly more programmatic. Let's see. Dr. L, do you want to, since they're sort of message related, do you want to maybe talk about whether or not LTBI becomes activated with COVID-19? Is there any information on that?
Not much. The only way that risk factor is the risk is increased is when the treatment for COVID, one of the treatments that are utilized for COVID is an immunosuppressant, like an IL-6 blocker. It's almost like a TNF blocker. So there are a lot of clinicians who have used these as adjuvant treatment for COVID, and it's an immunosuppressive treatment. So when it's given, ideally, LTBI is tested for, and not infrequently, we've had a lot of patients that have been found to be LTBI positive. So we need to closely follow them after they're sent home if they are given something like tocilizumab or one of these monoclonal antibodies. Yes, there is an increased risk if they have been subjected to immune suppression. But just by having COVID, there is no data to support that.
Great. Thanks, Dr.
There's another question on your chat box.
There is, but I'm also cognizant of the fact that we're a little bit over time. Do you want to very quickly talk about what you suggest for screening required during contact investigation and minimizing anxiety of possible TB during the pandemic?
Yeah, one of the public health reps have been asked to join in, but we have very little time. So a lot of the TB control work has been done virtually. So phone calls or FaceTime or WebEx have been increasingly used for these purposes. Other strategies was to kind of really do a symptom screen and educational discussion with patients on the phone. And instead of doing 2 TB tests, just wait a little bit so that you just have to do the 1 TB test. So you just wait for the 8 weeks after the contact is broken. So those are kind of practical ways to kind of minimize the need to move around if possible. And we would rather do the one shot thing, which is an IGRA, so that you don't have to come back and do the second reading in 3 days for a skin test. So those are practical steps, really minimizing contact.
Great. So I want to really thank all of the panelists for this really thoughtful and helpful advice and suggestions for helping communication around TB during this current pandemic and challenging time that we're all living through. So just to wrap up, if you have a final piece of advice that you'd like to give the audience for communicating effectively during this time, what would you like to leave folks with, if anyone wants to volunteer for that, just quickly?
Others can go first, but make sure I have time for that too.
Okay. Alyssa, do you have a final piece of advice?
No. No, I don't think that this can be wrapped up in a pithy short thing, unfortunately. Okay. Just take care of yourself so that you can take care of others.
See, there you go. That's perfect.
There we go, pithy.
Anybody else? Any final thing to keep in mind? Final piece of advice for communicating effectively during the pandemic?
I would just say briefly, I think we've touched on it a lot of times while we've talked today, but this is an abnormal situation we're going through, and it's normal to feel anxious. It's normal to have anxiety reactions. So if we can just let people share that with us if they want to, give them a little time and space to, you know, kind of let us know how they're feeling, and just to kind of normalize that for everyone.
That's wonderful. Thank you. So, Dr. L, yes, last word, Dr. Lardizabal.
That's not anything to do with communicating.
Okay.
But I think this is a very important time that that really has put the light on the confluence of politics and policies and health outcomes and social justice and economic, vast economic inequities. It's a time to really pause and ask ourselves, have we been complicit with all this? Have we not spoken up about you know, the hidden biases? Have we not called our representatives and senators when they've been dozing off in Washington? Have we done our civic duty? I think this is the time to kind of really say there is impact, and 120 deaths at this time is not a small number. And it really is very important to use this time to think about that, and really also you take the advantage of this unfortunate time to really emphasize the importance of maintaining a very strong public health infrastructure. So this is an opportunity, and I hope, as an optimist, that this will result in something better and brighter.
Thank you, Dr. L, for that positive closeout. And so I'm going to pass it back. So thank you to all the panelists. Thank you for all the audience for joining us. And I'm going to pass it back to Olivia for the wrap up.
Thanks, Nisha. Thanks for joining us all today. If you have any questions, please don't hesitate to email me. I have my contact information here. I will be sending out an email later today with an evaluation link where you can tell us anything else you're interested in hearing about in the future, and you'll also be able to request your continuing education credits there as well. We also know that, as Nisha mentioned, there were quite a few questions about kind of the programmatic side of COVID-19 and TB services. We did have a webinar last month where there was also a panel discussion where we talked about some of those other questions. So we do have the archive up on our website. I had the link here, but it's on our global tuberculosis website as well if you would like to watch that webinar recording. And so that's all I have. Thank you all so much for being here today and participating with us, and our really, really great panel. Thank you guys. You were really great. It was a great discussion.